Hi everyone, we're going to go ahead and get started. My name is Isha Weerasinghe and I'm the Senior Policy Analyst at the Association of Asian Pacific Community Health Organizations, or AAPCHO. AAPCHO is a national advocacy organization representing 35 community health centers, including 29 federally qualified health centers, who serve primarily Asian Americans, Native Hawaiians, and Pacific Islanders. AAPCHO, in partnership with the Migrant Clinicians Network and the National Healthcare for the Homeless Council, is co-sponsoring this training with the Administration of Children and Families, otherwise known as ACF, and the HHS Office on Women's Health. This webinar was also made possible with the help of the Health Resources and Services Administration's Bureau of Primary Health Care. On behalf of all of us, we want to thank you for joining us for today's webinar entitled Strategies in SOAR to Health and Wellness, Training on Human Trafficking for Healthcare Professionals. We're looking forward to present you with today's training about the importance of identifying victims of human trafficking within the health center before victims suffer more extreme circumstances. Joining us as your presenters today are Dr. Kimberly Chang, Mongan Commonwealth Fund Minority Health Policy Fellow at Harvard Medical School, Dr. Rochelle Rollins, Human Trafficking Health Policy Advisor from the Administration of Children and Families within the Department of Health and Human Services, and Elizabeth Corey, writer, advocate, and founder of Beating Trauma, LLC. But before we get started, I just wanted to review a few housekeeping items and let you know how you can participate in today's webinar. Here, we're looking at an example of the GoToWebinar attendee interface, which is made up of two parts. The viewer window, shown here on the right, or actually, yes, on the right, but maybe on the left in your screen, depending on your browser or computer operating system, allows you to see everything the presenter will share on their screen. The control panel, shown here on the left, but which may be on the right on your screen, allows you to participate in the webinar. Please note that all attendees are in listen-only mode and will be muted during the presentation. By clicking the orange arrow button, you can hide or show your control panel. You can also set the control panel to auto-hide or not to auto-hide by going to the View menu. You may submit questions in writing during the presentation by typing them in the questions field, and please indicate to whom the question is directed. We will be reviewing them as they come in, and we'll have a Q&A period after the presentation. Today's webinar is being recorded, and you will receive an email with a link to view a recording of today's presentation after the webinar. Lastly, before I pass the meeting over to our presenters, I also just quickly wanted to tell you a little bit about the Administration of Children and Families and about the SOAR training. The Administration of Children and Families is committed to ensuring that victims of all forms of human trafficking, adults and children, including foreign nationals, U.S. citizens, and lawful permanent residents, survivors of labor and commercial sexual exploitation, have access to the support they need to foster health and well-being. In September 2013, the Administration for Children and Families, with support of the HHS Office on Women's Health, launched a pilot initiative to enhance the healthcare system's response to human trafficking. The SOAR to Health and Wellness training was designed to help healthcare providers stop, observe, ask, and respond to human trafficking. The pilot training is part of the 5-year Federal Strategic Action Plan on Services to Victims of Human Trafficking in the United States, which calls for coordinated, victim-centered, culturally relevant, comprehensive, evidence-based, and trauma-informed care for victims and survivors. The purpose of this training is to highlight the importance of recognizing human trafficking victims within the health center context. We hope that this and future trainings will provide you with new insights and tools that you can use locally, regionally, and nationally. And with that, I'll pass the baton to Dr. Rochelle Rollins.
Thank you. Well, we are awfully glad that you are with us on the webinar. We hope that we give you some really good information that you could use and share with your colleagues. The SOAR to Health and Wellness training is also co-sponsored, as she said, by AAPCHO, Migrant Clinicians Network, and the National Healthcare for the Homeless Council. And this is exactly the way we had planned it. That it would be a federal effort with survivors, with healthcare professionals, with those from the community. So we're very pleased with this presentation. So the learning objectives for this SOAR training are as follows. We want to describe the scope and diversity and types of human trafficking in the United States. We want you to be able to recognize the common indicators and high-risk factors for human trafficking, and using your knowledge of trauma-informed techniques, enhance that and realize that the individuals that you're seeing potentially could be victims. Then lastly, we want you to identify local, state, and national resources for the victims. So basically, we want you to be able to see what you're seeing in your healthcare setting. At this time, we have a very short video that we're going to play for you from the Department of Justice, Faces of Human Trafficking video.
Human trafficking is slavery, and it happens all over America. Any child, any woman, any man could potentially become a victim of human trafficking. I am a victim of labor trafficking. I was victim of child sex trafficking, but now I own my body. Human trafficking is any kind of forced labor. It can happen to anybody. I am a mother. I am an author. I am a son. I'm an advocate. I am an educator. I'm a sister. I am a brother. I'm so much more than what happened to me. I am strong. I am brave. I am outspoken. I am compassionate. I am a survivor. I'm a survivor. I am a survivor. I am a survivor. I am a survivor. I am a survivor of human trafficking.
So our goal there in showing that was from the Office of Victims of Crime at DOJ. We wanted to be able to show you that it is much more broader than you may have seen on TV, that they come in different genders as well as races and ages. So at this time, we're going to look at the modules within the SOAR training. We're going to start first with STOP. We have to first start with the law. This is the federal law, the Trafficking Victims Protection Act of 2000, and the TVPA, and I'm going to bring all of it up for you to see. The TVPA states that there are 3 elements needed for prosecution of a trafficker. These are action, means, purpose. One of these elements needs to be proven. The actions include, as you can see on the left-hand side, recruiting, harboring, transporting, providing, or obtaining an individual. A key thing to know is transportation is not really required. You don't have to move a person to be trafficking them. Further, the TPVA says that one of the 3 means must be shown, and those means are either force, fraud, or coercion. Key point to know here is that if the individual is under the age of 18, force, fraud, and coercion are not required to prove a case of human trafficking. So again, that is the federal law, Trafficking Victims Protection Act. Now, what does means mean? Let's take a closer look at what that is all about. So what is it? It is force, fraud, or coercion. So force involves the use of rape, beatings, confinement. What is known is there's a seasoning process with victims, a breaking down of the victim. Trafficker uses isolation, physical or sexual abuse, starvation, keeping food, sleep away from them. Those are all forms of force. In terms of fraud, it's basically tricking them, making a false offer to induce a victim into the situation. This can be done through debt bondage or by offering a job which they're not going to get. It's different from the reality that they end up in, or pretending to have a romantic relationship with the victim. And lastly, coercion. That is basically defined as threats or serious harm or physical restraint against a person. So again, force, fraud, and coercion. Let's look at the types of human trafficking exist. There's a distinction between transnational and domestic trafficking in persons. Transnational, also known as international trafficking, is removing a person from their and exploiting them for either commercial sex or labor in another country. Domestic trafficking occurs when a person is exploited within their own country's borders. This can happen only miles from a victim's home or all the way across the country. There are 2 types of trafficking, labor and sex trafficking, which we're going to go into more deeply. Again, to remember that under the TVPA, any child under 18, whether they are a U.S. citizen or a foreign national who is induced to perform commercial sex, is automatically a victim of human trafficking. So you don't have to prove force, fraud, or coercion. Where is this happening? Well, labor trafficking, if you can see that there, we gave you some examples there. Restaurants, construction sites, when a casino's going up, you might wonder, why is it happening so quickly? Nail salons, also an example. The metro, here in D.C., we have a subway. You see panhandlers begging out. You might want to wonder, why are they doing that? Are they really doing that because they are in control of their destiny? This is not an exhaustive list of labor trafficking, just some examples. The next slide shows, where does sex trafficking occur? Sex trafficking occurs in street corners, casinos, hotels, the internet, major sporting events, escort service, truck stops. And those all enable us to have partners who can help stop the sex trafficking. Massage parlors. Those are examples of sex trafficking. The next slide is on scope of the problem worldwide. We want to make sure in this training that we're not just talking about the U.S. We want you to understand how big this problem is. It's a worldwide industry that generates $150 billion annually in illegal profits. The victims trafficked around the globe, about 55% are women and 45% are men. Every day, people of all age groups, genders, and ethnicities are trafficked across borders. Let's look at the U.S. In the United States, this slide shows from our National Human Trafficking Resource Center, which is our call-in center, the breakdown of sex and labor trafficking. You can see between U.S. citizens and foreign nationals. The United States is one of the top 10 countries in which people are trafficked. Many trafficking victims come from countries such as Mexico, Thailand, the Philippines, Honduras, Indonesia, Guatemala. But they really can come from anywhere. Potential victims. As I said, there are transnational trafficking victims and domestic trafficking victims. So I really want to talk about these high-risk domestic populations. Anyone can be a victim. Let's get that straight. But then also there are the very vulnerable populations that we need to look at. Among the diverse populations affected by human trafficking are children in the United States who are in systems such as foster care systems or involved with detention and juvenile justice. There are also LGBT populations that are at high risk for trafficking. Migrant workers are particularly vulnerable. Traffickers often prey upon racial and ethnic minorities, undocumented immigrants, and the poor and people with disability, since their experiences with these groups often make them reluctant to go to authorities. Victims by race and ethnicity. This is a Department of Justice study that showed of the confirmed sex trafficking victims whose race was known. You can see the breakdown in terms of ethnicity for both sex on the left and labor on the right. Included in here are 4.3% Asian for sex trafficking and about 15% labor trafficking Asian. Tribal populations have had generational trauma and inadequate law enforcement because of the distance that you have to go on the reservations. So as we talk about tribal populations, we also need to think about the boom towns. For example, in the Bakken region of North Dakota and Montana, where there's a large influx of men working on the oil fields. So when situations like that happen and there's a lot of men and not a lot of structure, you're going to have high cases, potentially high cases of sex trafficking. a very under-recognized population are male victims. I told you the percentages in an earlier slide. There's perception that men engaged in commercial sex are more susceptible to HIV than to violence, but that is not necessarily true. While limited data shows that boys are less likely to be under the control of a trafficker as compared to girls, they are still victims for exploitation.
Okay.
Hello, the audio is working now.
Okay, thank you. Sorry about that, everyone.
Good. Okay, next we're going to discuss who are the traffickers. There's many stereotypes out there about what traffickers look like, so we wanted to iterate for you what it is that a trafficker can look like. They can go from a very large scale to very small scale. You can have traffickers who are involved in organized crime, corporations, industries, governments, and gangs. An example of a large-scale trafficking situation, when over 500 men from India arrived to work in the shipyards in Texas and Mississippi. They came in on guest worker visas, but they were promised green cards for themselves and for their families. When they arrived in the U.S., they were unfortunately placed in overcrowded labor camps and subjected to psychological abuse, and were defrauded of their payment for their work. Many of them had paid as much as $20,000 in recruitment fees, which is the equivalent of many years' wages in India. Small-scale traffickers consist of family members, friends, significant others, and neighbors, small businesses, and local pimps or individuals. They may help with the logistics of buying and selling a small number of people. So, for example, Holly Austin Smith, who was a victim of child sex trafficking when she was 14 years old, in the summer between her 8th and 9th grade, she was getting ready to start high school, and she was very trepidatious about the experience. She met a man in a mall, and that man convinced her to run away. Unfortunately, right after she ran away, within hours after running away with him, she was forced into prostitution in Atlantic City, New Jersey. So that's a couple examples of how traffickers can vary. Next, I want to share with you a study out of the Covenant House. And the Covenant House actually services mainly homeless youth. And so they did a study with the homeless youth that they service, and most of these youth that were involved in sex trafficking were involved as minors, and they were domestic. So we refer to that as domestic minor sex trafficking, or DMST. These youth were surveyed to determine what their traffickers looked like. And amazingly, what was discovered in this particular survey was that 36% of the DMST victims were subjected to trafficking by immediate family members, which is defined as either their parents or somebody directly within their immediate family. This is very important information for us to understand, because when we see victims coming into medical settings and it appears that they are with family members, that does not mean that they are not being trafficked. We really have to understand that.
Thanks, Rochelle and Elizabeth. This is Kimberly Chang. I'm going to go over the second module of SOAR, of the Stop, Observe, Ask, and Respond training. The second module is Observe. Step 2 is to observe. What are the common indicators and signs and symptoms of a trafficking victim? So why is this training important? We want you to think about who is in your waiting room. The healthcare visit is a unique opportunity for healthcare professionals and the healthcare system overall to intervene in and end human trafficking. The problem has been underdetected and unaddressed in many healthcare settings. And this is why this training is so important, and we thank you today for sticking with us and listening to this training. So remember Dr. Rollins' discussion on who could be a victim of human trafficking. So I want to switch to the role of the federally qualified health centers. There are some representatives from the federally qualified health centers listening in, and we need to remember, who does the FQHC serve? Who do we serve? Remember who is at risk of being trafficked. The same vulnerable populations that are at risk of being trafficked are the very same populations which are served by federally qualified health centers. Those in poverty, the uninsured or publicly insured, racial ethnic minorities, and limited English proficient patients, also immigrants and refugees. Research has shown that trafficked victims are highly likely to come into contact with someone within the healthcare system. This means, again, that we have a very unique opportunity to intervene in this problem. A study by Baldwin and Associates of survivors of sex and labor trafficking showed that 50% had encountered a healthcare professional while being trafficked. Another study by Lederer and Associates of domestic sex trafficking survivors found that 88% had also encountered healthcare professionals while being trafficked. In both of these studies, none of these patients were identified as a victim of human trafficking. There was an opportunity to intervene that was missed. We don't want to miss any future opportunities. Next. You can keep clicking through it. As we have seen, victims of human trafficking encounter a variety of healthcare professionals while in captivity or bondage. This graph is based on an anonymous national healthcare survey of human trafficking victims by McKinney, Chisholm, Straker, and Associates in 2014. The respondents were either victims of sex or labor trafficking. A total of 117 patients were interviewed, and the percentages totals add up to 108%, as some patients saw multiple providers. As you can see, the most common healthcare professional encountered by human trafficking victims were those working within the emergency department, followed by primary care physicians, OBGYNs, and dentists. Now think about the community health center setting. They often have several of these healthcare practitioners in their setting, dentists, primary care physicians, OBGYN, or reproductive healthcare services. Sometimes they have urgent cares. There are some FQHCs that have adjacent emergency departments. So really, the FQHC setting is an important setting to identify victims of human trafficking. ER personnel are highly likely to encounter an individual being trafficked. And a previous study by McKinney, Chisholm, Straker examined emergency room personnel's understanding of human trafficking. The findings indicated that although 29% of staff understood human trafficking to be a problem in their emergency department population, only 13% felt confident or very confident that they could identify a victim. Less than 3% had been trained on victim identification. The lack of training increases the chances that a person being trafficked is misidentified, blamed, judged, or misunderstood. In addition, victims of other crimes such as domestic violence, child abuse, and sexual assault may also be experiencing human trafficking, which may not be recognized by the healthcare provider. The reality is that many victims are encountering healthcare professionals and are not being recognized. That's why we're having this training today. This is often due to various barriers that hinder identification. The barriers fall into two categories: provider-related barriers and patient-related barriers. When we think about provider-related barriers, we think about a lack of knowledge regarding human trafficking, as healthcare professionals can't recognize something if they don't know about it. This is why this training is so important. Misclassification of victims also occurs. For example, when a sex trafficking case is seen as a domestic violence case, particularly when the victim is romantically involved with the trafficker. Remember Dr. Rollins' earlier slides in STOP. Sometimes, as a form of psychological control, the traffickers will coerce the victims into romantic relationships. Some domestic violence victims may actually be human trafficking victims. Judgment may cause healthcare professionals to look down on those working in a commercial sex industry due to the stigma of prostitution, while a lack of cultural understanding may cause a healthcare professional to dismiss certain signs that the patient is being exploited. Under patient-related barriers, there are the fact that the patients rarely see themselves as victims for a variety of reasons, including shame of their circumstances, fear of the trafficker is very prominent, or previous poor experiences within the healthcare, legal, or social services sectors. There may also be a lack of awareness or recognition that they are a victim, and the words trafficking victim might not have any meaning for them. A lack of knowledge of U.S. health laws make it difficult for people to understand what's happening to them and that it's illegal. Others think that signed documents legitimize their circumstances. Think about the person who is under a debt bondage situation, has been coerced and deceived into a job opportunity that is completely different from what they signed on for. Foreign-born victims may have limited language proficiency or have difficulty explaining complex emotional trauma. It's also possible for victims, often international rather than domestic, to be illiterate and unable to read pamphlets or posters related to trafficking that may be in the officer waiting room. Being culturally aware in the healthcare setting is very important. Cultural humility means having self-awareness and reflection that allows for a respectful partnership with each patient regardless of culture. A person's appearance, hygiene status, ethnicity, socioeconomic status should not lead to preconceived ideas about that individual or influence the care that they receive. This doesn't mean that you have to know nuances of every single culture that you come across. It means acknowledging cultural diversity and helping to empower patients to convey respect for their actions and emotions while you're in the healthcare setting. This is vital for gaining their trust, especially if you suspect a situation of human trafficking. Some components of cultural humility are being open-minded, non-judgmental, and giving patient-centered care parallel to that of trauma-informed care, a topic that Elizabeth will address later in this training. So remember, step 2 of the module is to observe the indicators of trafficking. A mnemonic that may be helpful to you is to think about observe as being a patient being overly submissive, O, or exhibiting fearful behavior in the presence of others. B, they might have a buddy or someone who answers all of their questions in the examination room. This buddy could be the trafficker or someone working with the trafficker. Can you see or detect any signs of physical abuse? Does a patient have hidden bruises, scars from cigarette burns, or suspicious injuries? E, does the patient have English barriers? Do they have difficulty communicating with you because of language or cultural barriers? Domestic victims can also be lawful permanent residents who may also have language and cultural barriers. R, is the patient lacking any sort of identification, rare identification? V, is there a variety of health issues? There's a variety of health issues experienced by trafficking victims, and we'll talk about this a little bit more in the rest of the training. And finally, does the patient appear to be overly fearful or afraid? This could be regarding a procedure, the setting, the personnel, or the person accompanying them on the visit. When we think about these general indicators of being trafficked, we can place them into three large categories. These categories include indicators of being controlled, red flags, which alert the healthcare provider that something is suspicious, and physical indicators. Let's start by looking at control indicators in victims. All victims of trafficking are, by definition, under the control of his or her trafficker. This control can be exerted through direct threats using force or violence, or it could be psychological in nature. The trafficked person might be accompanied by a very controlling person who attempts to dominate the conversation and answer all of the questions directed towards the patient. The trafficker can commonly act as a translator for the victim or interpreter and may pose as a spouse or family member. In sex trafficking, a trafficker could also be someone sent to exert their control, and this person is often referred to as the bottom. There's other terms for this character. She or he is frequently the most trusted woman in the group under the control of that trafficker. She could be known as aunt, sister, wife, or wifey of the patient. Typically, she'll be older than the victim, and her role is to make sure that they act in a manner consistent with the trafficker's wants. When victims of sex or labor exploitation are accompanied by a controlling trafficker, they often display nonverbal signs of fear, shame, or anxiety, and they could also be restricted in their communication with the healthcare personnel. They may have their head down, frequently look at the person accompanying them for approval for their answers. Upon closer observation, you may get the impression that there's more they want to say, but they're afraid to say it. So you have to be very observant of your patient in the examination room. Alternatively, the trafficker might feel that they have enough control over the victim to allow them into the healthcare setting alone. But oftentimes, in those cases, they keep close communication by frequent texting during the healthcare visit or periodic phone calls. This has happened to me in my examination rooms with some of my minor patients during the teen clinic. Sometimes traffickers are able to achieve this level of control by fathering a child with the victim and keeping the victim's child with him or her, knowing that the patient, the mother, will be obedient and afraid for the child, and return back to the trafficker after the appointment. If you suspect a patient to be a minor involved in a commercial sexual exploitation, they may or may not appear to be under the control of another person. But you must remember, no matter how the child presents, that force, fraud, and coercion are not required in cases of child sex trafficking. So even if the child appears to be a willing participant, under the definition, the child in a commercial sexual exploitation is a victim of human trafficking. There are many red flags that could arise while getting a patient's history, and they're indicators of both sex and labor trafficking. A trafficking victim may not be able to provide information as simple as his or her address. Victims of sex trafficking are often moved. They're moved by the traffickers in a regional circuit, so they oftentimes don't know what city they're in, and they might ask the nurse or the healthcare professional, by the way, what city is this? While undressing the patient for the exam, the nurse or other healthcare professional might find multiple hotel key cards or large amounts of cash. These large amounts of cash may happen especially if the victim needs to have medical care. So remember that cultural humility means not judging the patient's behavior. Sometimes survivors are defensive and they could be hostile to healthcare providers because they have been treated poorly by people in the past, including healthcare professionals. Or they may have been trained by traffickers not to trust others. So utilizing the tenets of cultural humility means really just letting the patient be the patient and observing them, trying to reach out to them and gaining their trust, and not judging them, even if their behavior may be hostile or defensive. Other red flags include having no identification, what appears to be false or forged identification, or no idea where their documents are located. Further investigation may reveal signs of visa fraud, such as the person being hired with improper documents or someone else's identity. Sometimes domestic minor victims of sex trafficking are told to lie about their age. So you should be very suspicious if someone tells you they're older and they look very young. So if someone does not appear to be their stated age. The trauma that occurs within trafficking often causes patients to be poor historians and lose their sense of time, making them unable to place certain events within a normal timeline. In addition to this, they may have no contact with family or friends while in captivity. There's also the issue of trauma bonding, which means that patients can be trauma bonded to their trafficker, and they may make up facts that cause their story to keep changing. They might try to protect themselves because of certain criminal acts they may have committed, thinking that this information may lead to their arrest. Or they may be fearful of being identified and returned home to parents or legal guardians. Remember what Elizabeth said earlier, there's 36% of domestic minor victims of sex trafficking were family controlled.
Yes.
So they might be afraid of being returned home.
Right.
There's a reason why they may be running away. For these and other reasons, it's very possible that the healthcare professional will get a distinct sense that they're not getting the whole story and the patient is hiding something. Finally, traffickers don't usually allow their victims to visit healthcare settings at the first sign of a medical problem. So delayed care is a sign you should be aware of. Okay. So there are many physical indicators of trauma. I mean, victims of human trafficking are people. And you should think about the conditions of trafficking to get a sense of their injuries and their physical indicators. This is not an exhaustive list. Migraine, headaches, hearing loss, eye injury or strain, infectious diseases, tuberculosis, or infectious diseases that are normally prevented by immunization, dental injuries, scars, suspicious injuries such as fractures, concussions, bruises, or mutilations, neglected chronic illnesses and pain that have not been well managed. Other conditions could include lead poisoning, heat exhaustion, and silicosis from certain labor roles. Lastly, but very importantly, is noting that certain tattoos that might be found in the patient often located on the neck or lower back. Domestic traffickers commonly have girls under their control tattooed with their street name or some other phrase that communicates that they belong to the trafficker. It's a type of branding. Any tattoo that states property of or daddy is highly suspicious. I'm going to turn it over to Elizabeth now. She is going to share some of her experiences.
Yes, as a family-controlled survivor of child sex trafficking, I've had a lot of experiences within the medical community as a survivor and a victim of trafficking. And I just wanted, one of the things that I feel is really important to indicate here is that I was in the doctor's office and the hospital many, many times when I was a child with illnesses and physical ailments that had no cause and no cure. And often what would happen is that one of my parents would come with me and the parent would make excuses for why I was ill, or ask for a very quick diagnosis or some kind of quick cure. But what we would find over and over again is that my trauma-induced illnesses were just not explainable under normal conditions. And there was a lot of tests done on me to determine what was wrong with me, and nobody was ever able to make any true diagnoses in many cases. So I think it's also important that we understand that the way trauma affects us holistically, you know, it may not be something that is so easily explainable. So if you have somebody who is constantly presenting illnesses that don't seem to have a general cause or cure, it's something to consider. I think we're all coming to an understanding that stress causes illness. Well, extreme stress can cause extreme illness.
So again, this is Kim back. Think about the conditions in which a trafficking victim is held. These conditions are deprivation of food, shelter, sleep, extreme stress, as Elizabeth just mentioned, hazardous travel. Excuse me. Poor sanitation or conditions that cause poor hygiene, such as lack of access to clean water. Hazardous working conditions. Oftentimes, labor trafficking victims are placed in dangerous, dirty, or degrading working conditions. And lack of preventative health care. So along with trauma, victims of labor and sex trafficking often show signs and symptoms of neglect, lack of preventive health care, neglect of illnesses or injuries, skin problems, dental neglect, and malnourishment. You can see here that sexual and reproductive health issues are common in both genders for both labor and sex trafficking. Oftentimes there's an overlap. Infections caused by the use of sponges, cotton batting, and other materials in the vagina to stop menstruation. Unwanted pregnancy or neglected pregnancy complications, such as severe undiagnosed hyperemesis gravidarum or morning sickness, or significant blood loss from threatened or incomplete miscarriages. Abortion-related complications, such as retained products of conception, severe blood loss, or acute pelvic infections. Another issue encountered is that of underage girls who are often forced to take injectable Depo-Provera to stop menstruation. Anal trauma occurs when victims are forced to smuggle drugs, and they develop anal tissue tears from drug malfunction or systemic poisoning from the drug rupturing inside. This can also occur during sex. Anal trauma is common for both genders. Elizabeth's going to speak again now.
Yes, I experienced a lot of sexual and reproductive issues as a result of my trafficking, most of which I was never really even attended to until I was already an adult and started to attempt to have some kind of normal sexual relationship with partners outside of my trafficking situation. And some of the things that I was faced with, all of which were extremely stressful and increased my anxiety dramatically, were vulvodynia, which is a swelling of the vulvar gland, and it can make sexual intercourse extremely painful. So this was one of the issues which I dealt with during most of my 20s, and I was never able to get a real cure for that. There is no real cure for that, and as a matter of fact, the cause of it is still up for debate within the medical community. I also would experience severe anxiety at pap smear appointments to the point where they would actually have to medicate me with Xanax or some other type of medication in order to calm me down enough to be able to do a pap smear. And then I had fertility issues, and once again I will say no cause and no cure, because I didn't have what you might see when somebody is not able to conceive a baby. A lot of times you see things like polycystic ovaries and things of that nature. But in my case, I was suffering from long-term amenorrhea, where I would just not ovulate for years on end, and there was no reason for it. There was no actual sign of why that was happening. So it's really important that as we look at this type of issue, that we consider the fact that some people are presenting somatization of severe stress and trauma. So yes, and so for the next slide, I'm going to spend a few minutes talking about the psychological indicators of this type of trauma. And so in addition to the physical signs, a patient is going to exhibit psychological signs of trauma and increased stress due to the trafficking scenario. Substance abuse is very common in victims of trafficking because it helps them cope, but also because it is used as a control mechanism by traffickers. So that's also important to note. Signs of post-traumatic stress disorder or complex post-traumatic stress disorder may be found in this population. And so when you start talking about complex post-traumatic stress disorder, we start talking about some of these other symptoms that are listed here. For example, they may have emotional blunting, where the victim is actually kind of numb. I know in my case, I actually didn't cry until I was 34 years old, literally. And so I think it's important we understand that the reaction that we see from a trafficking victim may actually look like nothing's wrong, or that they are underreacting to their situation, and that could be why. Sleep problems are very common, depression, and of course, hostility, because hostility can be a very fear-based reaction. It's important we don't just see hostility as aggression. It's very fear-based. Low self-esteem, suicidal ideation is almost a given. I was recently at a table with a group of survivors, and one of the women at the table with us asked, who at this table has considered committing suicide? And every single one of us raised our hands, because it is absolutely a given almost that if you're in a situation and you see no other way out, that you will consider suicide as an option. Dissociation is probably one of the most common impacts of complex post-traumatic stress disorder. This is also one of the reasons why you may see that the issues with the story that you're getting from the victim. The story may be choppy, it may be changing. That is probably also caused somewhat by dissociation. Excessive shame or guilt and poor interpersonal relationships are kind of cycling back through some of that same violence that they may have already been experiencing, are very common. And then last, as I was talking about earlier, is this idea of somatization, where physical problems are coming up, but they don't seem to have, as it says here, an identifiable organic etiology. It's really important to note that somatization is a very real thing for a sex trafficking victim. So next, I'm going to introduce a short video, and I think it's really important here that that we listen to survivors, and not just because I am one, but because we talk a lot about trauma-informed care, and it can be a little bit of a cliche that gets used in the industry quite often. But to me, trauma-informed is survivor-informed. Because if we can understand where that survivor or that victim is coming from, then we are understanding their perspective, and that is trauma-informed. So make sure that when you're learning about trafficking, you're listening to survivors, because they really are the experts.
Important for doctors and nurses and care providers to understand that we are victims and not, just prostituting by choice. Coming in at 4 or 6 o'clock in the morning with no clothes on, tattoos, like in the neck area, lower back area, things like daddies or initials, bottom, looking pale, sick, like she hasn't slept in a couple of days, or that she's with a man or guy and he's referring to him as daddy, and obviously he's not. Or he's very persistent on her, like she cannot make a move, or he's right behind her. Or she keeps looking at him for his approval, like. Or she has her head down and holds her on the face, like certain areas, like there's, there shouldn't be black and blue, like on her chest. She didn't hurt herself. If it's winter and there's snow on the ground, they're coming in the hospital with open-toe shoes and a visitor. with no side, no hope. Even the side of sexuality. I think it's important for healthcare providers to also understand the mental, not only the physical that's going on with the young women, because keep in mind that they're being constantly manipulated, brainwashed, not to talk. Like you say, like it's not easy to deal with trauma. We deal with like certain things every day. So it's not easy. Like we might have an attitude, but the attitude is just really a cry for help. Sometimes they see that they're trying to, because like I've been to the hospital where they've asked me how many sex partners I've had, and me being like 13 years old, 14 years old, and I'm like, I don't know. Like I'm sitting there thinking, I don't know, I'm afraid. So you can tell that I'm nervous to give them an answer, and she's looking at me like there's something wrong, even if they don't understand, to show the support. I'm going to the hospital because I want help. I want you guys to help. They might hit that day where you're just so tired, and then you just want that help at that moment. This is how I went to hospital. I'm just like praying for somebody to ask me a question.